Hi all, and thank you for welcoming us back to Ethiopia for our third visit. During our last trip, we spent a lot of time speaking with the PICU nurses and nursing leadership, and were ultimately asked to develop a clinical education program to support learning in pediatric critical care and pediatric emergency nursing, focusing on clinical practice at the bedside. What we've learned during these past visits is that such an approach needs to respect your existing expertise and the realities of your clinical environment. You are already exceptionally resourceful, creative, and resilient, and you have learned to provide highly specialized care, largely through on-the-job experience and by teaching one another. But specialty training has been limited. The St. Paul's School of Nursing is addressing this challenge through the launch of their master's program in pediatric critical care nursing. Congratulations on enrolling your first class of nurses. That's incredibly exciting and a huge achievement. What we learned during our visits is that you do not lack insight or skill, but the structural support and processes needed to implement change consistently is sometimes a challenge. This program will hopefully be a tool that you can use to help problem solve some of the clinical challenges you encounter in your daily work. Your leadership has kindly supported this effort to protect your time away from the bedside to engage in this important project, so thank you. It is important to acknowledge that we, American nurses, even though we practice in highly advanced, well-resourced settings, are not direct counterparts. You, Ethiopian nurses, demonstrate a level of adaptability, clinical problem solving, and resilience that reflects the realities of your environment. In many ways, you are far more adept at navigating complexity with limited tools than we are. Because of this, you are the true experts in your practice, and you are the best positioned to teach new nurses who join your units. Our role is not to educate you to do your jobs. Instead, our aim is to support you by helping to organize and formalize the knowledge, skills, and competency you already possess by helping to develop structures and a competency-based orientation. We are simply putting framework and clarity to the expertise you live every day. You are already conducting the orchestra. We are only here to help arrange the notes so that your expertise can be consistently shared, sustained, and strengthened. During this first teaching block, our focus will be on the top 3 items on this slide, and if time allows, we'll spend some time discussing interdisciplinary teamwork and family communication, likely more during our tabletop sim exercise. But for this block, we really wanted to focus on your clinical bedside practice and early recognition of pediatric sepsis. And then in the golden hour, and that's the term that we refer to that first hour, usually when they're in the ED or if they're in the PICU and they've just begun to develop signs of sepsis, and how important it is to quickly recognize that and initiate fluid if they're starting to show signs of fluid refractory shock, and to initiate antibiotics within that first hour. And then in this case study, the patient will progress and decline and need mechanical ventilation. So what does that look like? What does your environment look like? What are the challenges in your environment when you have to initiate mechanical ventilation? And then Robin will spend a good deal of time talking about mechanical ventilation itself and competencies around that and the equipment you use. Our learning objectives, specifically as they apply to infection prevention and control in this study block, will really focus on appropriate precautions for a child with suspected sepsis. And we'll talk about PPE use during high-risk procedures and how to implement infection control for intubated patients. And as always, we need to talk about hand hygiene and cleaning principles in shared or limited spaces. The learning objectives specifically for sepsis recognition and management are to recognize the early warning signs of pediatric sepsis. In the WhatsApp group, we did share a video and some articles that really summarize the various tools that are out there around triggering sepsis identification, and then we will get to a more contextually appropriate sepsis trigger for your work environment and really want your feedback on that. We focus a lot on initiating the sepsis bundle of care, which is recognizing the need to initiate oxygen therapy, give IV fluids and antibiotics within that first hour of recognizing potential sepsis in a child. The case study will focus on the monitoring of deterioration and respiratory failure and what you need to do to intervene. And then how do you communicate those concerns promptly to your physician group and the rest of your team? There's a tool we sometimes use called SBAR, so we'll go over that too. We may spend more time in the tabletop sim talking about SBAR than in this didactic, but we'll see. So why do we need to care about sepsis? Pediatric sepsis carries very high mortality rates in Ethiopian hospitals, with PICU sepsis mortality often near 30 and 50%, and septic shock over 60%. Children frequently arrive late because they're coming from rural areas of the country, or they're cared for first in other hospitals and then referred to you. And sometimes it's been a week since the onset of their symptoms, and they arrive in decompensated shock by the time they even get to you in triage. Emergency departments and wards sometimes lack consistent pediatric sepsis screening tools, which can lead to delays. Again, not your fault in fee-for-service systems, which are not uncommon in the world. If a family or a patient can't afford to pay for some of the testing that goes with some of these tools, then you're not going to be able to use them. But there are other tools that we'll talk about a little later that don't use any fancy testing, and you do have the resources to implement, and we'll talk about some of the pros and cons of using those systems. Emergency departments in Addis Ababa, they function as some of the main referrals for the entire city, and you absorb a large volume of critically ill children. So strengthening your sepsis care has an outsized impact on the care of kids all over Ethiopia. I don't want you to feel bad about those mortality rates. Again, I can't emphasize enough that you are taking care of the sickest children in your country, and they're coming to you already decompensated much of the time, so that alone is going to result in higher mortality rates and some poor outcomes. That doesn't mean there's not room for improvement. There always is. I just don't want you to feel bad about some of these numbers, because you are providing great care already, and the kids you're taking care of are so sick. So some action points we can think about. You could work on implementing a standardized screening tool through a collaborative clinical practice committee that includes your nurses, your leaders, your physicians, fellows, all of those people, respiratory therapists, everyone that participates in the care of your critically ill patients. Put together a committee and look at different tools that are available using the resources you have at your disposal. So that could include a pediatric early warning system, or perhaps some sepsis triggers that, again, we'll talk about a little later. We're going to emphasize the golden hour care, which means rapid antibiotics, fluids, and perfusion assessment within the first hour of arrival to your organization, or as soon as sepsis is recognized in, say, the PICU. And you're already investing in training emergency and ward clinicians on shock recognition and initial resuscitation. So you're already on the right track. Other things you could do, establish a data dashboard or do QI cycles to track sepsis outcomes and bundle adherence. So do a QI quality check on charts and review the charts and see how quickly antibiotics were administered in a septic patient, as an example. Improving pediatric sepsis care is one of the highest yield interventions to reduce preventable deaths in Addis Ababa's hospital and St. Paul's. So really hoping that we can make the most of this time together. There was a really good article published, I believe, in 2022 that specifically looked at sepsis and Ethiopian PICUs. There were two hospitals in Ethiopia where they pulled this patient population from. One of them was St. Paul's, and patients from St. Paul's PICU, there were 114 patients overall, were enrolled over an 8-month period from October 2022 to May 2021. There were more female than male patients with a 1 to 1.2 ratio, and the average age was 4.5 years. Half the patients arrived from rural areas of Ethiopia, meaning it probably took them an extended period of time to get from wherever they were when they developed symptoms to you. 38% of them were severely malnourished, which is something important to keep in mind, and we'll talk about that a little later on. 58% were fully vaccinated. 32 or 28%, about half, died. 32 died, and about half died within 7 days of their admission. But 82 lived. 71.9% of the kids enrolled in the study lived. So go team. The top diagnoses were severe pneumonia, septic shock, and complicated meningitis. 23% of all the patients developed a complication in the PICU, but it was a little unclear reading through the articles what those complications were, so hoping you all can enlighten us on what those complications were. But if they developed a complication, those patients were 2 times more likely to die. A diagnosis of sepsis was associated with higher mortality rates. Use of sedative drugs was also associated with higher mortality rates, and the study authors speculated it was because it took longer to wean the patients off a ventilator, which resulted in more ventilator-related complications. But use of mechanical ventilation was associated with lower mortality rates, significantly lower. In fact, 55% lower mortality rates when a patient who needed to be ventilated was. Okay, let's get down to business and review this case study. So you are a nurse in triage, and a little girl who is 4 years old is sitting in her mom's lap, and you start your triage. And what you learn about her is that her name is Lydia, and her mom tells you that she's had a fever for 3 days. She's not quite sure how high it is. They don't have a thermometer, but she feels really hot per mom. She doesn't use the word lethargy, but she does tell you that Lydia has been sleeping far more than she normally does, and sometimes she's difficult to wake up or to get her to open her eyes. And mom says she's breathing funny. You also know in talking to mom that Lydia attends a crowded daycare, and other kids in that daycare have recently had fevers and coughs. Lydia doesn't have any other chronic illnesses that her mom reports. So at this point, you know that Lydia has a pretty high fever. You've checked an axillary temp at triage, and you found her fever to be 39.8. Mom also tells you that Lydia really hasn't been eating anything and has had very little to drink in the past 24 hours. And you can see before you've even counted her respiratory rate for a full minute, which you will, that she's breathing too fast. And she does indeed have decreased responsiveness and only seems to be opening her eyes when mom loudly says her name. She has no other travel history and no other comorbidities or illnesses identified. So what else do you want to know about Lydia at this point? So in keeping with ETAT and our triage assessment as a nurse, we're going to keep in mind our A, B's, and C's. So starting with our airway, then breathing, then circulation, then we can move on to disability or neuro. So airway, her airway's patent, but she is pretty lethargic and she's not protecting her airway well. You count her respiratory rate for a full minute. It's 48. You note nasal flaring, subcostal retractions, and when you check her O2 sat, it's 89% on room air. Her heart rate is 164 beats per minute. Her cap refill is longer than 3 seconds. She has weak peripheral pulses, and her blood pressure is 75/45. When you move on to disability, you find a GCS score of 10. If you're doing AVPU, She gets a V because she's only responding to verbal. She's not spontaneously opening her eyes. And then for exposure, she is still pretty hot. Her temperature's above 39. When you do a glucose check, her glucose is 56 and her extremities are cold. So what do you do now? Where do you start? Okay, so in reality, this is a patient that you're going to probably rush back to your red area. But let's just pause for a minute and talk about what we think is going on here. You don't have to make a diagnosis, but we all kind of start putting the puzzle pieces together right from the get-go. So what are we thinking is going on with Lydia? Possibly pneumonia as her source. She's coughing, she's in respiratory distress, and she has a fever. She's potentially in respiratory failure. We know that because her oxygen saturation is low. Her work of breathing is significant. She's tachypnic. She is using intercostal muscles, all of those accessory muscles to really breathe. Nasal flaring. She's lethargic. And she's quite possibly in septic shock. And we know this because her pulses are thready. She's tachycardic. Her cap refill is prolonged. These are all things that we need to be thinking, oh, shock, we might need to start implementing that sepsis bundle. And then what's our initial management going to be? And we always need to think ABC, airway, breathing, circulation. So where do we start with Lydia? Airway. She's not protecting her airway very well, and she's pretty lethargic, so we're going to open that airway. And that may just mean lying her down on the stretcher, putting some towels or a blanket under her shoulders to lift her head up and open that airway by tilting her head back. And we want to initiate oxygen, in this case, probably via a non-rebreather to start. And then we want to get an IV in and potentially, and we'll talk about this in greater detail, prepare to administer a 20 ml per kilo bolus of normal saline or LR, whatever you have available to you. Again, we'll talk in detail more later about which fluid to use in this situation and how much to use based on your nursing assessment. And then antibiotics. Usually it's a broad spectrum antibiotic. Ceftriaxone comes to mind. With our littler patients, you may be thinking about gentamicin too, but Lydia is 4 years old, so we're thinking probably ceftriaxone, but we're going to rely on our providers to let us know. And really, we need to be focused on getting that IV established or an IO established and getting that antibiotic administered within an hour of her presentation. Blood cultures. If it's appropriate, go ahead and draw them, but don't delay your antibiotic administration if you're having a hard time getting enough blood back for cultures. You always want to try, but don't delay antibiotic administration to get a blood sample for that culture. And then at this point, once our IV is established, we also want to correct that glucose of 56. So let's talk briefly about what shock is. To put it very simply, it's inadequate tissue perfusion. For whatever reason, the cells aren't receiving enough oxygen. That can lead to organ dysfunction and failure if left unrecognized and untreated. In pediatric patients, they have really strong compensatory mechanisms, which means they can really fight off late signs of shock for a very long time until they can't anymore. And when you know they're in trouble is usually when they have that prolonged cap refill and hypotension. Hypotension means they're no longer compensating and they're in decompensated shock. In that state, mortality rates skyrocket. The mortality rate for a child presenting in decompensated shock is high, with studies showing rates over 30% and one as high as 90%. It just depends on the study and patient factors. But things that are predictors of mortality are delayed presentation. So any delay in treatment can significantly increase the risk of death. The type of shock also matters. Certain types of shock, such as cardiogenic and septic shock, have a higher mortality rate. For example, one study found a 100% mortality rate for a mixed type of cardiogenic and obstructive shock. And a greater number of organ dysfunctions are correlated with higher mortality rates as well. So there are 4 different types of shock, and when we teach the emergency nurse pediatric course, we often use this car analogy to talk about these different types of shock. So an empty tank, that's your vascular system. Does it have blood and fluid in it or not? A broken pump or engine, that's your heart. Is it working or not? Broken pipes, those are your blood vessels. Are they leaking? Are they overdilated? And a blocked pipe refers to obstructive shock, such as in the case of cardiac tamponade. So an empty tank, that's typically hypovolemic shock, either from massive blood loss or inadequate circulating fluid volume in the case of major dehydration. There's cardiogenic shock, where for whatever reason, there are so many different reasons for the heart to fail. And then distributive shock is when the vessels dilate and become leaky. And then obstructive shock, as I mentioned, is like a cardiac tamponade. So what kind of shock is Lydia in? So septic shock is a type of distributive shock, and it's complicated. You could spend an entire semester just learning about the pathophysiology of septic shock. It is not easy to unwind and understand. In the notes for this slide, there's a great article called Septic Shock in Children, Rapid Recognition and Initial Resuscitation in the First Hour that walks you through all of these because we don't have time to do it today. But the short version is septic shock causes massive systemic inflammation, an endothelial dysfunction, which is a fancy way of saying the capillary bed becomes leaky and you get tissue edema. The maldistribution of blood flow, also a fancy way of saying that all of the vessels dilate and you have hypotension as a result. Myocardial dysfunction, so all of that inflammation depresses the cardiac contractility and limits the ability of a child's heart to compensate for those wide blood vessels, so they can no longer support a healthy circulating blood pressure. And then that impaired oxygen delivery that we talked about. So the combination of hypovolemia, vasodilation, myocardial depression all lead to poor tissue perfusion, cellular hypoxia, and metabolic acidosis. And then we have, on top of all of that, coagulation abnormalities. So this activation of coagulation pathways that can lead to microthrombi or clots, worsening tissue ischemia. We're going to sidebar for just a few slides and talk about different screening tools. There are several sepsis screening tools in use around the world. The gold standard is fairly new. It's the Phoenix Pediatric Sepsis Criteria, and it was just validated in both high and low resource settings and presented to the world just last year in 2024. The Phoenix criteria defines sepsis as an infection with life-threatening organ dysfunction, and that includes 4 organ systems that they look at specifically. So they look at respiratory, cardiovascular, coagulation, and neurologic systems for variables. And sepsis is then defined by a Phoenix sepsis score of at least 2 points in children with a suspected infection. And septic shock is defined as sepsis with at least 1 cardiovascular point in the score. And we're going to dive into this just a little bit. But no, it's difficult to implement the Phoenix sepsis criteria in some low resource settings because patients can't always afford to purchase some testing such as an ABG or a lactate level. But we are going to go into a great little tool that you could potentially use in your work environment in a few slides. So hang in there with me. Again, the Phoenix criteria defines sepsis as an infection with life-threatening organ dysfunction, which includes a 4-organ system model with respiratory, cardiovascular, coagulation, and neurologic variables. So on this slide, we're just looking at respiratory. And sepsis is defined again with a Phoenix scoring system of at least 2 points. So how the heck do you calculate an SF ratio? And what is an SF ratio? Well, in the Phoenix score, the SF ratio stands for SpO2 or pulse oximetry to FiO2 or the fraction of inspired oxygen ratio. And it's used as a non-invasive surrogate for the PF ratio, which requires an invasive arterial blood gas management. So you can't always get an arterial blood gas on your patient, but you can usually determine what their SpO2 is and how much oxygen they're breathing in. So FiO2 means fraction of inspired oxygen, or the percentage of oxygen the patient actually breathes in. And we know that room air is 21% oxygen. So that FiO2 would equal 0.21. SpO2 is measured peripheral capillary oxygen saturation, the little probe we put on their finger. And it's a measure of how much oxygen is bound to hemoglobin in the blood, and it's expressed as a percentage. And if we recall, Lydia's is 89%. If the patient's saturation is greater than 97%, you don't even have to do the SF ratio because oxygen saturation curves flatten at high levels, making estimates unreliable. So what score would we give Lydia using the Phoenix criteria for respiratory dysfunction? Well, her SF ratio is 424, so she doesn't get credit for that because it's quite high, meaning good. However, she does require respiratory support. We had to put a non-rebreather on her. So because of that, she would get 1 point under respiratory dysfunction. So this is again where the Phoenix scoring system can be a bit problematic in lower resource settings. Lactate isn't always readily available due to the ability to pay for the test, or perhaps the lab doesn't have the reagents to run the test that day. And even if you can run the test, you may not always get it back in time to diagnose and treat identified sepsis, so it can be time limiting. You could use a MAP, or mean arterial pressure, to calculate with a manual or automated blood pressure, but continuous arterial pressure monitoring probably isn't available. Coagulation studies are also limited by cost of performing the test and the speed by which the test can be resulted, if it's even available. So these are the other 3 organ systems in addition to respiratory. You can look at your cardiac dysfunction, and again, with the Phoenix score, in order to be diagnosed with septic shock, a patient has to have at least 1 point in the cardiovascular system. So did you have to start a vasoactive medication? They would get 1 point, up to 3 points. Did they have an elevated lactate? You may not be able to run that test. And what's their MAP? You have to take the time to calculate the MAP if your monitor isn't doing it for you, or perhaps you don't. If you have to do a manual blood pressure, you'd have to do some math. So these are all things that add to the time that you're trying to make this diagnosis. For neurologic dysfunction, we typically use the Glasgow Coma Scale. I think with ETAT, you typically use AVPU. Either's fine. And then with coagulation dysfunction, you may not be able to get platelets and INR or for fibrinogen level either because it's cost limiting or time limiting. So I think it's good to be aware of the Phoenix scoring system because it is becoming the standard of care. However, there are alternatives. So again, don't beat yourself up if you can't always do these things. There are things you can do very readily in the context of your work environment. This is the proposed diagnostic flow sheet to characterize patients using the new criteria. This new criteria, as I mentioned, it was presented to the world via JAMA in 2024. We will give you a link to this article at the end of this presentation. Please know that this article is exhaustive. It is packed full of a ton of information that you do not need to memorize for the purpose of this teaching block. It's really just there as a reference tool for you if you want to dive a little deeper into anything in particular. This article probably covers it to some extent. I think it's important to note that the Phoenix sepsis score is not intended for early screening or recognition of possible sepsis and management before organ dysfunction is really obvious. So it might not be a great tool to use in the ER anyway. It may be a useful tool to use later on in the PICU as a way to track your patient's progression when they're already admitted. Most kids admitted to the PICU in shock will be in your PICU for at least 7 days. So this could be a good tool to use later on down the road, but it's very time limiting in the environment of your ED having to wait for these tests to come back. So there are really signs and symptoms we can look at to really determine if our patient's in shock or not. And we're going to do that with the next slide. This is the Pediatric Septic Shock Collaborative Triage Tool, and it doesn't use any fancy testing, only the equipment you have available. So this is something you could potentially implement in your care environment. So it starts with, does the patient present to the ED with a concern for infection or a fever or a temperature abnormality? Are they hyperthermic? Are they hypothermic? If yes, we would want to continue along this sepsis algorithm. Then you look at the patient. Does the patient look critically ill without going through all of these other things? You can usually tell if you have to rush a patient straight back to the red area. But if you're not sure, you can continue with the shock triage tool. So you're going to obtain a full set of vital signs to include a blood pressure and a temperature, perform a brief history and physical exam to include a mental status exam, which could be as simple as AVPU. You're going to look at their skin. Are they pale? You're going to check their pulses. Are they strong or are they thready? What's their cap refill time? And is this patient high risk? So a high risk patient, you can look over to the right in table 1, would be a patient with some kind of oncology diagnosis or a known malignancy. They might be asplenic or have sickle cell disease. Did they have a bone marrow transplant? Do they have a central line or indwelling catheter, portacath for instance? Have they had a solid organ transplant in the past? Severe MRCP? Are they immunodeficient for any reason at all? If so, that would make them a high-risk patient. But then there's this checklist we go through. So do they have a temperature abnormality? Too high, too low? Are they hypotensive? And you can look at age with normal vital signs or vital signs that would put them into the context of septic shock on the right. Are they tachycardic? Are they tachypnic? Is their cap refill abnormal? Is their mental status abnormal? Is their palpable pulses abnormal? And is their skin abnormal? If any of those things are true, you really want to know at that point, is this patient compensated or uncompensated? Do they have a normal blood pressure or an abnormal blood pressure? And then if this patient meets 3 or more of those above 8 criteria, or they're a high-risk patient and they meet 2 criteria, you can assume they're in septic shock and move on to treatment. Bring them right back to the red area, get your physician involved, and have a conversation about your assessment findings and whether or not it's appropriate to continue treating as if this patient were in septic shock. All right, back to Lydia, finally. So let's look at her respiratory system. And what do we see when septic shock impacts the respiratory system? No fancy testing. What can you see? You can see a rapid respiratory rate, or tachypnea. You can see cyanosis, and you can see increased work of breathing or retractions. With Lydia, she's not protecting her airway well. She's occasionally snoring. Her respiratory rate is elevated at 48 breaths per minute. She's nasal flaring and has subcostal retractions, and her room air sat is 89%. So at this point, what are our nursing interventions? What do we want to do? Right, we want to deliver oxygen. And how are we going to do this? Are we going to use a nasal cannula, a non-rebreather, a simple mask? What would you choose? If you thought non-rebreather, you would be right. In this case, a non-rebreather would be appropriate to deliver the highest concentration of oxygen possible while preparing potentially for intubation. And we want to be prepared with a bag valve mask as well in the event she further decompensates and the team needs to intervene with rescue breathing while preparing for that intervention of intubation. Next, let's look at the cardiovascular system. How does sepsis impact the cardiovascular system? What can we see? What can we feel? What can we gather with the tools we have? Do we know if she has decreased cardiac output? Yes, because we know her pulses are thready, her cap refill is prolonged, she's hypotensive, she's tachycardic, and she's potentially mottled as well. Lydia's heart rate is 164 beats per minute. That's elevated for her age. Her cap refill time is 5 seconds. That's too long. Her peripheral pulses are weak. Her skin is mottling and her blood pressure is 74/45. How does sepsis impact the cardiovascular system? What can you see? What can you feel? What tools that you have can you use to see how sepsis is impacting Lydia? Does she have decreased cardiac output? Is she mottled? Does she have a prolonged cap refill time? Is she tachycardic? Is she hypotensive? When we think about Lydia's exam, we know that her heart rate was 164 beats per minute. That's too fast for her age. Her cap refill time was 5 seconds. That's too long. Remember, normal cap refill is 2 seconds or less. And her peripheral pulses are weak when you palpate them. Her skin is mottled and her blood pressure is 74/45, which we know is too low. So what are your nursing interventions? What are you going to do next? If you thought, I'm going to establish an IV, you would be correct. Ideally, in this situation, you want 2 IVs. And per PAL's guideline, if you're unable to establish an IV after 2 attempts, you should go ahead and place an IO. At which point, you're going to plan to administer 10 to 20 mils of fluid per kilogram over 5 to 20 minutes. I would rely on your provider to give you guidance on that. And I also want to point out that for patients who often present with severe malnutrition, you really want to give that fluid bolus slowly because they're at higher risk for developing congestive heart failure with big fluid boluses. So anytime with any patient you do something, you're going to want to reassess. But in particular, in the setting of severe dehydration, in the setting of severe malnutrition, you really want to listen to those lung sounds and do an assessment to see if there's any risk of congestive heart failure for this patient, because that's really going to dictate how much and how quickly you give her fluid. So we did something. We gave a fluid bolus. Now we want to reassess. We want to reassess her heart rate again, her cap refill in particular, her blood pressure. We want to palpate those pulses. Anytime you do an intervention, you want to reassess your patient. Okay, so what do we do about that glucose of 56 now that we have an IV in place? Well, per the ETAC guideline, hypoglycemia is defined as less than 54, or when you have suspected hypoglycemia if the child is unconscious, convulsing, lethargic, or severely ill. You don't need to check a glucose, just give the glucose assuming that it's needed. We know Lydia has a glucose of 56. Quite honestly, she is severely ill and lethargic, so probably a good idea to just go ahead and give the dextrose. You're going to give D10. We don't give higher concentrations of glucose to kids because it can be extremely irritating to the vein when it's given peripherally, and if it extravasates or infiltrates, it can cause tissue necrosis. So stay away from high concentrations of glucose. You want to be able to dilute your 50% dextrose down to 10%. How do you do that? There's different ways to do it. Again, this is one of those areas where you are far more expertise than we are because we typically do not have to dilute our dextrose. And if you look under the notes for this slide, there's 3 different options depending on the size of the syringe you have available. But we know that Lydia is 14 kilos and the recommended replacement of dextrose is D10 at 5 mils per kilo, so she would need 70 mils. If I only have a 10 cc syringe, I'm going to drop 2 cc's of dextrose 50%, and then in the same syringe, I'm going to drop 8 mils of normal saline, and that now gives me 10 mils of D10. This is a ratio of 1:4. That's the correct dilution. If you have a 50 cc syringe or a 100 cc bag, there's directions under the notes on how to dilute your 50% dextrose down to 10% dextrose. Sepsis mortality is associated with delays to appropriate antimicrobial therapy. In simpler terms, this means that the longer it takes you to recognize sepsis and give antibiotics, the higher your risk of patient death. So it's really important to recognize you have a septic patient and to get broad spectrum antibiotics into them as quickly as possible. You have to do broad spectrum initially because it's going to take days to get a blood culture back to know exactly what you're dealing with. So I think in your setting, you frequently use ceftriaxone as that first line empiric therapy. And empiric therapy just refers to the initial choice of antimicrobials while you're waiting for those blood cultures to come back. Broad spectrum therapy refers to the use of single or multi-drug antimicrobial therapy with activity against multiple groups of bacteria and pathogens. So ceftriaxone kills lots of different bugs, basically. There is a link in this note to the Surviving Sepsis campaign and international guidelines. And it discusses antibiotic use extensively, more than we need to understand for our purposes here. But if you really want to know, go ahead and click on that article, get yourself a cup of coffee, a really strong one, and have at it. Read away. And good for you. So here's another little sidebar. Which fluid is the best fluid to choose when you have to give a pediatric patient with sepsis a fluid bolus? Well, unfortunately, the data that we do have available to us is conflicting, so not at all clear. The good news is there's a multi-center study underway right now that Boston Children's is also participating in that is comparing giving normal saline to giving Ringer's lactate to children as boluses and sepsis. So hopefully we'll have some more definitive guidance soon. Until that happens, I think it's important to really understand the potential implications of choosing one over the other. And we're not going to go into it in depth, but you do have 2 links on this slide that if you're interested and want to learn a little more, click on both of them. They're pretty quick, straightforward reads. But the takeaway is that normal saline has a higher concentration of chloride ions than human serum. And if you administer large volumes, hyperchloremia occurs, which can cause metabolic acidosis. The dilution of sodium bicarb with normal saline may also contribute to acidosis. So Ringer's lactate is often avoided in septic patients due to concerns about worsening lactic acidosis. However, this concern is unfounded. Ringer's lactate contains sodium lactate, not lactic acid, and modern clinical practice often places significant emphasis on blood lactate levels, which can lead to misinterpretation and confusion. Ringer's lactate solutions do contain calcium, which you do need to know is incompatible with ceftriaxone, particularly if you're caring for a neonate, where calcium ceftriaxone precipitates have led to fatal outcomes. So if it's a neonate and you're using Ringer's lactate, because that's all that you have available, you have to pause your bolus, flush your line with normal saline, then give your ceftriaxone, flush your line again, then you can resume giving Ringer's lactate. You cannot give both ceftriaxone and Ringer's lactate at the same time. And then just a quick note on the slide, the pH of the human body is what? Roughly 7.4. What do you think the pH of normal saline is? It's 5.5. And what do you think the pH of Ringer's lactate or lactated Ringers are? 6.5. So one potentially could be less likely to cause metabolic acidosis than the other. You need to use what you have available, but this is just something to keep in mind, particularly if you have to give large volumes of either. You do need to think about metabolic acidosis and how you might have to treat that moving forward. And then moving on, another little mini sidebar. It's a good idea to be familiar with the 4-2-1 rule to calculate maintenance fluid in any patient. Also a good idea when you come on shift to double check the rate of the maintenance fluid to be sure it's safe and correct for your patient. So if we'll recall, Lydia weighs 14 kilograms. And using this formula, you can very quickly calculate her maintenance fluid rate. So using this formula, you're going to take her first 10 kilograms and times that by 4, which gives you 40. And then up to 20 kilograms, you're going to times by 2. So you only have 4 more kilograms, which is 4 times 2, which is 8. So 10 times 4 is 40. 4 times 2 is 8. Her maintenance fluid rate is 48 mils per hour.